Hello, everybody. My name is Emily Janoch. I'm the Director of Knowledge Management and Learning at CARE, and welcome to our briefing today on vaccines. As you know, this is incredibly important work that the COVID vaccine is an incredible part of what the tools we have to fight the pandemic, and your support for CARE is critical to our success over the last 2 years. It's critical to the work we've been able to do. And sadly, as new variants keep emerging, your continued support is more important than ever. We know vaccine equity is the only way to end the pandemic, and that's support that we need around the world. The Omicron variant proves what we've known for a long time. No one is safe until everyone is safe, and your commitment and your support are a huge part of that work. Investing in COVID vaccines and vaccine equality means making sure we're paying the healthcare workers who administer those vaccines at the last mile, getting vaccines from the tarmac to the arm. That requires investment in the global population and in the healthcare workers who are administering vaccines. Our Fast and Fair initiative does just that. We support vaccine delivery in 22 countries, and there are new countries adding to that list all the time as those conditions become right and as we are able to start those initiatives. Since we've started, we've worked to promote vaccines, organize delivery, train healthcare workers, and ensure access for people who need it most. We've also been able to mobilize people to get the COVID vaccine. That means 126 million people have gotten COVID vaccines in the places where CARE is working right now. And 263 million people have gotten better information, either through mass media or through one-on-one coaching and support. For example, in Bangladesh, the CARE team worked to take the second worst performing district in the country and turn it into the second best district in the country, adding more than 1 million people to the number of folks who'd been vaccinated. How did they do that? They did that by helping people register to get vaccines. In that district, very few people have access to the internet. And so the team actually went door to door with tablets, helping people do the online vaccination registration, and then following up with them to make sure that they understood where and how to go for their appointments. In Ecuador, CARE is working with the Ministry of Health to improve registration and information. CARE Peru created videos, online videos, to help Venezuelan migrants learn how to register for vaccination. In Laos, CARE sent staff to the Ministry of Health to help with data entry and vaccine registration. Those are just a few examples of the work we're doing around the world to make sure that everyone who needs a vaccine is getting a vaccine. And because CARE is committed to ensuring that local voices are heard first, we have a great panel with us today. We're honored to have two of our partners from South Sudan, Willy and Loice, who are going to give us a firsthand account of what this reality looks like for them. And we're also excited to have Dr. Angela with us. So Dr. Angela, can you please introduce yourself for the audience?
Sure, thank you, Emily. My name is Dr. Angela Waguer. I'm the Senior Director for the Health, Equity and Rights team, based out of Washington, D.C., Maryland. The team is largely in Atlanta, but also global, in Mongolia, in Benin, as well as Egypt and other parts of the world, including our local country offices. I'm originally from Uganda, medical doctor by training with a master's in health policy planning and financing, and happy to be at CARE doing this great work on the Fast and Fair vaccine initiative. Thank you.
Great, thank you. Willie, can you introduce yourself for the folks on the line?
Thank you so much. My name is Willie Camilo, Health Manager for Barium and Aluminum counties. These are the two counties located in the extreme north of South Sudan. And I work very closely with the State Minister of Health in the provision of the basic package of health and nutrition services. I'm currently supporting 11 health facilities that comprise of 1 hospital, 5 primary healthcare centers, and 6 primary healthcare units. We also have a team of 160 community-based workers who we work very closely with to deliver health services. Thank you.
Thank you. Loice, over to you. Can you introduce yourself for the folks on the phone?
Thank you very much. As you've heard, my name is Loice Awino. I am the health and team leader in Western Baragazal, one of the care officers based in the field. I work closely too with the State Minister of Health and other stakeholders, other allied ministries like the Ministry of Information, Education, Agriculture, and the rest to ensure that healthcare reaches the most vulnerable in Western Baragazal. Western Baragazal consists of 3 counties, that is Raja, Jur River, and Wau. CARE is based in Wau, but with COVID-19 vaccination, we also support Jur River and Raja counties because of gaps in funding. Currently, we support 8 health facilities, including 1 hospital in provision of primary healthcare services, secondary healthcare services, and community services. We have a total of 126 social mobilizers and 128 healthcare workers who are seconded by the Minister of Health. Thank you.
Thank you. So thank you so much for the work you're both doing in different parts of South Sudan. And we also have Dr. Emmanuel, who coordinates across South Sudan. So Dr. Emmanuel, can you introduce yourself for the group, please?
Thank you. Yeah, so my name is Emmanuel Ojwang. I am Health and Nutrition Coordinator for South Sudan. So I support health and nutrition services across the country, and we are supporting directly a total of 40 health facilities. Out of these 40 health facilities, we have 4 hospitals, and the rest are primary healthcare units and primary healthcare centers. Apart from that, we also have 51 nutrition facilities that we are supporting to provide both preventive and curative nutrition services. And we also have 2 mobile clinics that we are supporting to provide services to about 40,000 internally displaced persons that were displaced from one of the states called Jonglei to Central Equatoria. So that is what I do. Thank you so much.
Thank you. And it's an important reminder that COVID vaccines are part of the story, but the rest of the health system still has to function. There are other barriers still in place. So I'm going to exercise my moderator privilege and ask a couple of questions to get us started. Dr. Angela, I'd love to start with you. We've been talking about this message for close to 2 years now. We say Tarmac to arm. What does Tarmac to arm mean, and why is that important?
Tarmac to arm is critically important. It's a phrase that came to my mind when the vaccines were initially approved. And the word in the global community was that vaccines will be pushed out to other countries. And so the fight started with advocacy, which is the first pillar of our vaccine response campaign, advocacy to get the vaccines out to countries that need it. And we suddenly started seeing global North countries hoarding the vaccines. Even the first and second dose, don't even talk about the booster dose. So when that hoarding began, we realized that we need to advocate for Tarmac to arm. In our global strategy for the vaccine response campaign, we have 4 pillars. The first is advocacy, the second is facilitate, the third is protect, and the fourth is mobilize. The advocacy piece is as CARE with our other international non-governmental organization partners, as well as local civil society organizations, as well as our regional and country, both partners and country offices, advocate for vaccines to get out there. But the real hard work comes into the fact that even when vaccines reach the tarmac, when the plane lands and brings in the vaccines, the issue becomes, how do we get those vaccines from the tarmac into the arms of individuals? And so that facilitate part, which means work with national governments, our country offices, and local civil society organizations to ensure equitable distribution of the vaccines, first and foremost, at the national level, and then support national governments, UNICEF, and other partners to move using the cold chain to ensure vaccine is viable, moving it down to the district, to the local primary healthcare facility, and then to protect frontline health workers who are the ones who are actually going to put these vaccines into arms. The vaccines are not going to get into the arms of individuals without frontline health workers. We believe that frontline health workers are critical, and frontline health workers include clinical frontline health workers, non-clinical, formal and informal, paid and unpaid, though we're working on them being paid. So frontline health workers, our support to them is part of the Tarmac to Arm philosophy. And finally, mobilize communities, because I've just come back from Uganda. Across the African continent and many of the countries in the global south, there's huge vaccine hesitancy. So how are we going to combat vaccine hesitancy? How are we going to boost vaccine confidence? By mobilizing communities, working with our country officers to work with local civil society partners, as well as key stakeholders and influencers, social influencers in the community, using tools like the community scorecard that CARE has advocated to mobilize community. So Tarmac to Arm is that facilitate part, the protect frontline health workers and mobilizing communities to accept the vaccine, that it is safe, that COVID-19 does threaten their lives, and that this will bring about greater protection for them so their economies can bounce back and they can also be healthy for their families. Thank you, Emily.
Thank you. And Dr. Emmanuel, one of the things that all of these barriers have proven about getting the Tarmac vaccines from the Tarmac into arms, one of the results of that has been a growing gender gap. So, originally in South Sudan, you saw 70% of people were getting COVID, people testing positive for COVID, but were women, but only 25% of the people getting the COVID vaccines. Can you talk to us about why that was happening and what role CARE has played to help close this gap?
Yeah, thank you. Thank you so much. So, yeah, that is something that we noted at the beginning in the locations where we work, that in terms of, diagnosis, because there was very limited diagnosis, but for those that were being diagnosed to have COVID, up to 70% were women. And this was particularly so in the populations that, the refugees, the IDPs, and other populations that have challenges accessing health services. So when the vaccination started, we noticed that there were huge challenges for women to access vaccines. And looking at the figures in terms of access to vaccination, we noted that women were only 25% of those that were accessing vaccines. And that was not just in one location, but in several locations, including Juba. Initially, it was thought that it was because of the difficulties of transport, the responsibilities that women have, especially in South Sudan. But then we noted that this also affected even health workers, female health workers that were working in the health facilities. So what we did is that we identified female champions, women leaders. For instance, in some of the locations that we work, we have female health ministers, we have female health workers in our health facilities, and we also have mother-to-mother support groups in the nutrition programs that we run. So we used these female leaders that had already received the vaccine to talk to the communities, because the biggest fear was that the vaccine would interfere with fertility. And so we had to use these female leaders, including our own female health workers, to address these fears and talk to the community and engage them and try to give them information, including using the radio and other means of mass communication. And what has happened over time is that we have noted that the gap has actually narrowed from about 25% of women accessing vaccination to about 45%. So right now we are at 45 to 55, and we are hoping that as we move along, this gap will eventually be completely, narrowed, and there will be equal numbers. This is very important to us because in South Sudan, 70% of health workers are actually women. So even when we are talking about frontline health workers, majority of them are women. When you talk about households, women are the ones that carry out most of the responsibilities, including when the government adopted the home-based care, women are the ones that were providing care for patients at home. So it is very important that they are protected, and that is why we have placed a lot of emphasis, and we have we needed to ensure that this gap was narrowed. Thank you so much.
Thank you for the work you're doing to get there. Seeing that gap narrow has just been so impressive in such a challenging environment to say, here is a big problem and we know how to fix that. So thank you for the work you're doing there. Willie and Loice, I'm going to turn to you. It's really an honor to have you here today. You are doing the most incredible work, you and others like you around the world, working at the last mile, talking about frontline healthcare workers. Many people talk about frontline healthcare workers. It's just such a pleasure to have you speaking about the experiences that you're having. Can you talk to us about what you're seeing on the ground? What are the biggest challenges and the biggest struggles right now in getting vaccines to the people who need them most?
Okay, I think I'll go first. Thank you for this opportunity. And it's a great honor for us to be here today discussing about the last mile distribution of the vaccines. Now, what you're seeing in Western Baragazal, for example, where I am, at first, as Dr. Emmanuel reiterated, is that women were not going for vaccines, but with the bringing on board of women leaders into vaccination campaign, has really improved the uptake. Something unique about where I work currently is that we have more female health workers than male, and that has really boosted the uptake of the vaccines. I am also pleased to inform that our governor is also a woman, and she even took the first dose of the vaccine so as to allay the needs and the anxiety that was in the community. We are also using female committees. We have health committees, which we have made sure that they have female leaders, at least a chairman, a secretary, who are able to give out information to the community. Challenges that we face in the field are accessibility. Most of the health facilities are far, so getting women to walk into those areas is not really easy. Number two, the number of vaccines that come are few. So you find that most men go first to get the vaccine. So like the first round, second round, the vaccines were really few and people were eager to get vaccinated, but the vaccines got finished before. Another thing is the issue of health workforce. Getting trained vaccinators is not easy. As you know, like in South Sudan, the National Ministry of Health indicated that they need qualified health workers to be the vaccinators. But where we are, we just find that we have people who are not trained health workers who are vaccinators doing the majority of the vaccination. So getting qualified health workers to administer the vaccines was also an issue. So the issue of human resource, the issue of incentive, because these people again need motivation. The issue of mobility, transportation. We have other areas even in WOW where we've not reached so far, and that is where the big chunk of population is. So there is a whole mixture of challenges that prevent the administration of the vaccines, or rather the vaccines reaching the population or last mile distribution of vaccines. I will not forget to talk about the cold chain. So many facilities lack cold chain. So what we are trying to do is that we have mobile teams which are being supported by Gavi, even though the teams are very few, that will move around with call boxes vaccinating communities. But again, it's not issue. We still come back to the issue of funding because these people need transport. They need transport, they need allowances. And again, in those areas, there's insecurity. So we need to do a lot of clearance with the UN, with the government, and these are areas which are perceived to be IO, even though currently we are talking about a signed peace deal. Yeah, that's what I would say briefly about Western Baragazal. I'll back to you.
Thank you. That's really an incredible set of challenges across a range of different issues. Willie, what does this look like from your perspective? What are you seeing in the areas where you work?
All right, thank you so much. CARE is taking a leading role in the provision of COVID-19 vaccination activities here. When you look at the setup of South Sudan generally, there are significant access constraints due to lack of roads, infrastructure, and also the vastness of the country. Vaccines and supplies are currently being airlifted from Juba, the capital, to the various field locations, and CARE takes the role in the distribution to the different vaccination sites, while ensuring that the cold chain is maintained at all aspects of the the distribution. We are actually providing support supervision to the vaccination activities by monitoring the quality of vaccinations and also ensuring that any gaps that we observe are immediately addressed. We also support the teams with the required logistics such as fuel and also to ensure that the adequate supplies are in place. As care, we also seen that for the community to turn out for good vaccination services, they need to have good trust, especially with the vaccinators. And we have ensured that the vaccinators undergo proper training to be able to provide quality vaccinations that do not raise any avoidable adverse human errors. I mean, adverse effects following vaccination due to human errors. For this location that we actually operate, we have seen that there is uncontrolled border access between South Sudan and Sudan, and the number of COVID cases reported in Sudan have been very significant. So due to this uncontrolled number of, uncontrolled border crossing, we are seeing a significant number of new arrivals who are coming in, but due to the limited testing capacity, we are unable to actually have a clear idea on the actual number of people who are actually having COVID-19. Currently, we have 158 cases that have been tested cumulatively since we started the testing of COVID-19. And this might just be a tip of the iceberg considering the limited test capacity and also the uncontrolled border crossing areas. So from our side, we have tried to scale up the uptake of the COVID-19 vaccinations by ensuring that we conduct outreach activities. This is a team which moves to the different areas that cannot be accessed by car, and they go and provide vaccinations at community level. In addition to this, we have also expanded the number of fixed vaccination sites. Initially, there were 2. Right now, we have a total of 6 fixed vaccination sites, and we are seeing an improvement in total number of vaccines being provided. One challenge that we are facing across all the areas is that there is a general problem with the supply of vaccines. The vaccines that we receive are a very small quantity compared to the actual number of populations. So of all the vaccination that we have provided, we have reached approximately 1.4% of the total population. And this is very small if we are to expect a significant improvement in terms of vaccination effect as a result of herd immunity. So these are some of the challenges that we are facing. And I think if we had adequate supply, we would be able to see a significant number of vaccinations being provided. On the issue of disparities between male and female, we have also taken advantage of key women leaders, especially those working in the government. During the launch of COVID vaccination activities, we have discussed with them and they have accepted to take a leading role as an example on the launching dates. And this has encouraged many other women to also join the queue and turn up for the vaccination activities. So these are some of the updates that I can provide as far as our locations are concerned. Thank you.
Great, thank you so much for sharing that. So Dr. Emmanuel, I want you to talk a little bit, if you can, about this idea of vaccine hesitancy. We see that all over the world. It's a problem in the United States. It's a problem in many places. Both Loice and Willie have talked about vaccine hesitancy, the importance of building trust. What are some of the things CARE has done? What's the campaign that we've been working on to try to reduce vaccine hesitancy?
Thank you so much. So there are various causes of vaccine hesitancy, and specifically talking about COVID-19, the vaccination. What we have seen is that there is a lot of misinformation that has gone on, especially in the social media. So there is the talk about what I had spoken about, especially females, the belief that vaccination or the COVID vaccines would interfere with their fertility. And that is something that is very close to most of the communities. And then there is also the talk that has been going on in social media that the vaccine was developed very fast, and therefore they are not very sure. They want to see other people to get it fast before they get it. And then also the various vaccines, because we have seen different response on the AstraZeneca vaccine, the Johnson & Johnson vaccine. Those are all challenges that we have faced. So in terms of what CARE has done, CARE has been working with communities. One of the things that we have done that has really been of help for us is the relationship that we have built with the community over the years. And so we have actually utilized this to work with the community leaders, like my colleagues have said, from the level of the ministers of health to the lowest level. And given that we are not just providing health services, there are a wide range of services that we are providing, including protection services, food security and livelihoods, nutrition. So it means that in some of the locations, we have been working for over 20 years, and therefore we have built trust. Because if you look at locations like where Loice works in Wau, we have been working there since 1993, in Pariang as well. So over the years, it means that the people that we started working with when they were young, they're actually now men and women. And the only people they know, the only organization they know is CARE. So that has helped us, because when we started engaging them, they actually said that they don't think that CARE can, lie to them. CARE cannot give them something. If CARE is involved in the vaccination, then it means that, it must be something that is good and something that is going to benefit the community. So that is one of the things that we did to utilize the good relationship that we have built with the community. Apart from that, working with other partners, because there are other partners involved in provision of education, for instance, in schools. So mobilizing people through the education system, when children, for instance, girls and boys are, educated about immunization, then they go and tell their parents. That has been of help. And also utilizing all the meetings, like for instance, when there is food distribution by WFP and the rest, then we engage the community. So community engagement through the various platforms has been very key in turning the tide against hesitancy. The last one, and the one that we've been talking about, is that we have specifically targeted women because of various reasons, what I mentioned before. And this has helped us to see that the uptake of vaccination in amongst women has improved over time. So what we are seeing moving forward is that there has been a lot of emphasis on the supply side of the vaccination, but we need to also invest on the demand side. Apart from addressing the hesitancy issues, there is also, the staffing, what my colleagues have mentioned, and ensuring that there is transport, and continuing to engage the community and ensuring that we have staff that are well trained and motivated, and as much as possible, we avoid adverse events following immunization. Because in South Sudan, that has actually been one of the leading causes of hesitancy. When they see that someone is vaccinated and then they go ahead and develop adverse events, especially if they are avoidable and they are related to the skills of the health worker, then that is one of the things that we have addressed to ensure that our staff are well trained and motivated, and that as much as possible we limit. And we also have a team of people that are trained to respond to any adverse events, should there be one. Thank you.
Thank you so much. And that's just such an incredibly powerful statement about the importance of trust and the importance of the people who are in the communities. That's what we call the frontline health workers, the people who are really there. So before we open it up to the broad group, Dr. Angela, one last question for you. What do we mean when we say you need to invest not just in buying the vaccine, but in the delivery system and the healthcare worker? What does that investment look like? And who are we asking to make that investment?
Thank you, Emily. And thank you, Dr. Emmanuel, for that powerful summary of what it takes to increase vaccine confidence so that the vaccines actually are taken up by the populations that we're trying to serve. And what do we mean by vaccine delivery is that it's a human being who actually puts the vaccine into an arm. It's a human being who accepts the vaccine to be put in their body. So the investment needs to be made in the frontline health worker. My colleagues on the panel have mentioned everything from providing a frontline health worker transport, a bicycle, a motorbike, an umbrella, a raincoat, as things that are as simple as that, but are as powerful as that for a frontline health worker to show that they are valued. So to protect them by first giving them the equipment that they need to reach the villages or the rural populations or the urban slum or the foothills of Mount Elgon, wherever it takes to go reach that individual. And then everything from perhaps a phone that has an app to an iPad or a tablet that can register the information. We need to digitalize the way we collect this information, because can you imagine 7 billion people need to be vaccinated around the world as we approve the vaccines for even children. 7 billion people. We cannot do this on paper. We cannot do this on paper. We need to digitalize. So we need to make investments into the digitalization of not only national healthcare systems, but primary healthcare system facilities that can link their data to the national system, can link their data to the community health worker or frontline health worker who goes out to that community. It means ensuring that the frontline health worker is also vaccinated, that they also find the time and the resources to be able to be vaccinated themselves. It requires investments into PPE, personal protective equipment, everything from gowns to masks to gloves, ways in which they can be protected from getting infected themselves or infecting others. And it also means training. Dr. Emmanuel spoke very powerfully about the need for training and mentoring. Our Bihar model out of India is one of the most powerful examples of investment in frontline health workers, which leads to true outcomes. Reductions in maternal mortality, reductions in neonatal mortality, reductions in infant mortality over 10 years funded by Gates. So out of those kind of examples, we see that frontline health workers are key, are absolutely key to moving the vaccines into arms, and also investing in the communities to ensure that community meetings are held so that those social influencers are able to talk to their community and be able to make a difference in terms of their attitudes towards the vaccine. Please know that social media went ahead of all of us. Social media went ahead of all of us. The amount of myths that are embedded in people's minds, we have a lot of work to do. Everything, as Dr. Emmanuel mentioned, to fertility issues, to my body's gonna blow up in 2 years, to somebody has implanted a chip in me. The social media myths are so powerful and embedded in people's minds that we need to make those investments in the country teams and the local civil society organizations, literally putting investments into those local communities in order for them to hold those meetings with social influencers, women leaders, faith-based workers, imams, priests, pastors, community leaders, local council leaders, clan leaders, to talk to the community and say, this is COVID-19 disease. These are the different vaccines. These are potentially the side effects that might happen. And these are the side effects that will not happen. And this is the efficacy of the vaccine. I have taken it, take it as well. It's boots on the ground work that we need to invest in order to make a difference at the community level. And who needs to make these investments? It's both the public sector, meaning the national governments, the US government, global North countries, but it also requires the private sector, corporations, multinationals, the private sector entities in the countries where we work, but also the nonprofit sector. And the nonprofit sector includes organizations like CARE, but others. And how do we as CARE get those investments we need? Through private donors, that is largely our base, and also the US government, as well as private corporations. So those are the investments that are needed in order to push this envelope of the 4 pillars of our vaccine strategy, which has proven effective. 1, advocacy at the global and national levels, facilitating the distribution so that it's equitable, so that women are not left behind, protection of frontline health workers across the whole spectrum of frontline health workers, as well as the whole spectrum of what they need, and then mobilizing communities to reduce vaccine hesitancy and increase vaccine confidence. Thank you, Emily.
Great, thank you. So we're going to open up to questions from the audience today, and we've got a couple of questions already in the chat box, so I'm just going to start. Can you discuss the risks of not reaching the global vaccination goals? We've said we need to vaccinate 70% of the world. What happens if we don't? And why is that an essential goal even for us here in the US? Dr. Angela, you're on mute.
Sorry, I didn't know who you were directing the question to, but I'll go ahead and jump in.
Thank you.
COVID-19 anywhere is COVID-19 everywhere. If we in the global north think that we are going to be safe by making sure we are vaccinated, the first and second dose and the booster shot, we are sadly mistaken. If we don't immunize enough of the global community, variants will emerge. The Delta variant was the first one. It was horrendous. It was deadly. It took hold and it spread fast. Right now we have the Omicron variant, which has also resulted from the fact that not enough people have been vaccinated. This virus is extremely smart, like all viruses. It will mutate knowing that it has found a naive population, especially an unvaccinated population. So we need to work together as a global community, because when it comes to COVID-19, and I have been working in public health for close to 30 years, I thought HIV was a pandemic that like no other. COVID-19 is beyond HIV. HIV was sexually transmitted when it is sexually transmitted largely, but here you have COVID-19, which is transmitted orally, literally by breathing. This is something every individual does. A baby breathes, a child breathes, a woman breathes, we breathe. We cannot live without breathing. So it's a different type of a disease which spreads by the very being of us as humans. Sexually transmitted diseases, intravenous drug use when it comes to HIV is literally an act which oftentimes is chosen, sometimes not, obviously, but you can see the difference. So COVID-19 is a disease that if we don't figure out a way to control it globally, it will come home to roost. Thank you.
So Willie and Lois, there's a question for you in the chat box. What message do you have for decision makers to really make them understand what you need?
Okay, thanks. I will go first again. The greatest message that I have for the decision makers, all the decision makers in the world, is that we really need to find a way of combating this disease. As Dr. Angela said, this is a strange virus, a strange disease. And if we don't tackle it, if we don't get the whole population vaccinated, if we don't get mobilizers to reach out to every household to have people vaccinated, then we'll have a lot to deal with. Our economy and everything will be affected. And when everything is affected, then, we will not be there. So we just need more funding for COVID vaccination, especially also in Africa, Sub-Saharan Africa, South Sudan, where I work, where there is really a big funding gap. We need more health workers. We need capacity building. We need mobility. We need a commitment from the South Sudan government so that we are able to tackle vaccination the way it should be. Thank you.
Great, thank you. Okay, so we have, Willie, is there anything you want to add to that answer?
Yeah, one message that I think I need to put across, I think it is quite important to ensure equity in the distribution of the vaccines. This is very key because it is one of the pillars to ensure that all the different parts of the world are reached with the vaccination. Thank you.
Thank you. Okay, Dr. Emmanuel, this one's for you. How do we dispel the belief that these vaccines are too new to be safe?
Okay, what we have done and the most successful strategy we have employed and we have realized significant, success is using the community themselves. Because, when you're working with the community, there are people in the community that are trusted. People that, when they talk, when they tell the community something, they believe it. And these are the community leaders, the religious leaders, the traditional leaders. And these are the people that we have used. So what we did is that we approached these people and they were the first ones to take the vaccines. And when they took the vaccines and the population saw that, they were okay, and what had actually been spread, like Dr. Angela said, there were strange, messages that being spread in the social media. So when the community actually saw that these leaders who are trusted by the community received the vaccines and that they were okay and nothing happened to them, then that was a message to them that the vaccines are safe. So using community leaders, including women leaders, has been very important for us in trying to address some of the myths and the beliefs and the misinformation that the community had. Thank you.
Great, thank you. Okay, we're going to do the last question now. We're not going to be able to get all of them, but the last question I want to pose to the panelists is, what gives you hope? And Willie, maybe we can start with you.
Thank you so much. Well, considering the trend, starting from the time when we rolled out the vaccination activities in Barium and Aluminum, we have seen a significant increase in the uptake of the vaccinations. When the vaccines are delivered, they get utilized within a very short period of time, as compared to at the time when we just introduced the vaccinations. So this gives me hope that the community has realized the importance of the vaccination. There is improved demand, and if we address the issue of supply, we'll be able to reach a significant number of people in the community. Also, in addition to this, the positive support from the local authorities, all levels of the authorities, when we started talking to them about the COVID vaccination, it has been very positive, and this also gives me a lot of hope. We work together with them. They are fully involved in all stages of the vaccination process, and this gives also confidence to the community that they are in safe hands. Thank you so much.
Thank you. Loice, how about you? What gives you hope?
Okay, thank you. What gives me hope is that women in the area where I work are advising themselves to go for vaccines. Healthcare workers, care staff themselves have also gone for the vaccination. They were afraid, but now they went for vaccination and are also encouraging others to go for vaccination. Another thing is that we are using the little resources that we have to encourage the vaccinators and the vaccination teams to go out, and they are equally encouraged. That is what gives me hope. Back to you.
That's incredible. Thank you so much. And we're going to wrap up here because we told everybody we'd end at 9:45. I can say one of the things that gives me hope is colleagues like you watching the incredible work that you're doing and seeing the challenges that you overcome with grace and cheer every day. Is just an unbelievable privilege to be able to be a part of it. So thank you for sharing your experiences here today. We're going to wrap things up. Thank you, Willie, Loice, Dr. Angela, and Dr. Emmanuel for your time and for the incredible work that you're doing right now. There really is no solution to this pandemic for anyone in the world if we can't close the gap, if we can't think about what is the lived reality for billions of people, and how do we make decisions that serve them, even when those are not the lives that people who are making the decisions are living. So that's despite the efforts, these amazing efforts that our colleagues are doing, people all around the world, frontline health workers everywhere around the world are doing. It's not enough. We need more. We need to invest more because we will only be safe when everyone is safe. And the more people who can't access the vaccine, the higher risk there is for everyone in the world. So we understand that CARE's role wouldn't be possible without support from people like you. We know we wouldn't be able to do this work and see these changes in the world. And in some cases, as Willie and Loice, Dr. Emmanuel mentioned, over 20 years. This is support that builds over time, and building that trust means when there's a crisis, we can act fast and we can act effectively. That is founded on support from people like you. So thank you for your continued solidarity and support and your continued engagement around these issues. Thanks to everybody for coming today, and I hope you have a great rest of your day.